Hello everyone, I am Dr. Zubair. I am a consultant pulmonologist, and today we will be discussing an important topic with regards to MRCP exam, that is pneumothorax. Pneumothorax is important. Usually you will get one or two questions or even more in the exam about pneumothorax. So let's start. Pneumothorax simply means there is collection of air in the pleural space. If you see the normal lung, the pleural surfaces are closely opposed together, but when air leaks from the lung into the pleural space, then that compresses the lung, causing it to collapse. And this air in the pleural space, that is called the pneumothorax. Pneumothorax can be spontaneous, which means that it occur without any obvious cause, or it can be due to trauma. The spontaneous pneumothorax can occur in normal, healthy, young people when it is called as primary, and it can occur in those who have got respiratory disease like COPD or interstitial lung disease, then it is called as secondary pneumothorax. Traumatic pneumothorax can occur due to trauma like road traffic accident, or it can occur after some iatrogenic procedures like central venous line or pacemaker insertion. The hallmark of presentation, clinical presentation, is sudden onset. There can be shortness of breath or there can be pleuritic chest pain. Sometimes the scenario will mention both of these symptoms, sometimes only one of them, but they will always be sudden or acute in onset with history of minutes or at the maximum some hours. So whenever you get a scenario with sudden onset chest pain or sudden onset shortness of breath, you should think of pneumothorax. A close differential would be pulmonary embolism. How will you differentiate? On the basis of clinical examination. In pulmonary embolism, the examination will be all normal, while in pneumothorax, on the affected side, there will be reduced chest movement. And the key finding on examination is hyperresonant percussion note, which will differentiate pneumothorax from pleural effusion. In pleural effusion, there will be reduced chest movement, there will be absent or reduced breath sound, but the percussion note will be dull in pleural effusion, while it will be hyper resonant in pneumothorax. So, on the basis of these findings, you can differentiate between pulmonary embolism, you can differentiate between pneumothorax and pleural effusion. Remember, in pulmonary embolism, clinical examination will be normal. The respiratory examination, that is, the patient can be breathless, the patient can have tachycardia, but on auscultation, that will be normal. On percussion, that will be normal as well. When there is scenario of pneumothorax and the patient has got severe tachycardia, especially hypotension, blood pressure less than 90 systolic and 60 diastolic, patient has got other signs of respiratory distress, then that means patient is in tension pneumothorax and you cannot wait for further investigation. You should act immediately with needle decompression in the second intercostal space. Chest X-ray findings, or sometime you will get a chest X-ray in the exam as well in MRC part 2. There are two findings which will help you in diagnosing pneumothorax on a chest X-ray. Obviously, you will have to correlate with clinical findings, but on X-ray, if there are absent lung markings, here you can see these white lines, these are blood vessels or vascular markings in the lungs. You cannot see any vascular markings or lung markings here on the right side. And the second finding is the collapsed lung border or the visible visceral pleural line. When both of these findings are present, then that means there is a pneumothorax. In patients who are supine, who are in ICU, you will see deep sulcus sign. This part of the lung, you will see that this black shadow will be extending downwards. That will be the deep sulcus sign. The management of pneumothorax depends upon how big the pneumothorax is, how many symptoms the patient has, and whether the patient is clinically stable or not. If the pneumothorax is small, less than 2 centimeter, and asymptomatic, then only observation and high flow oxygen is given. If the pneumothorax is large, more than 2 centimeter, or the patient is symptomatic, patient is having chest pain, patient is having shortness of breath, then the first step in primary pneumothorax is needle aspiration. If needle aspiration fails, which means the pneumothorax is persistent, or it is the second episode or recurrence of pneumothorax, then chest drain is inserted and fluoridesis is done. Fluoridesis is done to prevent the recurrence of pneumothorax. If the signs of tension are there, patient is hypotensive, then you have to act immediately with needle decompression, and then that is followed by chest drain insertion. And remember one thing, the needle aspiration or needle decompression is done in the second intercostal space anteriorly in the mid-clavicular line. Chest drain is usually inserted in the triangle of safety on the lateral side of the chest. There are certain exam tips which can help you in diagnosing a pneumothorax. Young, tall male usually means primary spontaneous pneumothorax, COPD or interstitial lung disease, secondary pneumothorax. If pneumothorax happens after a procedure like central line insertion or PPM insertion, pacemaker insertion, then that is iatrogenic pneumothorax. So just to recap, if in the exam scenario you get a case, a patient presenting with sudden onset dyspnea, sudden onset pleuritic chest pain, think of pneumothorax. Other important differential is pulmonary embolism. But on the basis of examination finding, which will be given there in the scenario, you should be able to differentiate between these two. And if there is tension pneumothorax, do not select chest X-ray in the options. You should go for immediate needle decompression. Thank you.